Okay, good morning, everyone. Lovely to see you all. Thank you so much for joining this session this morning. My name is Sati Rai. I'm Member Engagement Manager at the Northern Housing Consortium. For those of you who aren't aware of who the Northern Housing Consortium are, we're a membership body for the social housing sector. We represent local authorities, housing associations, ALMOs and combined authorities across the three government northern regions, the North East, North West and Yorkshire and Humber. I am also the lead on the Housing, Health and Care programme that you'll hear a little bit more about shortly, and I lead on the warm and dry priority as well. So just before I sort of do a wider sort of introduction to the programme and the session this morning, just a bit of housekeeping, which I'm sure you'll all be very much familiar with. As I mentioned just before, some of you might have missed it, this session this morning will be recorded and it will be shared with you all after the meeting over the next sort of couple of days. Once we've got it sort of uploaded, it will be uploaded maybe potentially on the Boost platform. But again, all the instructions will be included in any email that goes out after this session. Obviously, I really appreciate if everybody could stay on mute whilst you're hearing various different speakers speak this morning, just to avoid any kind of background. I do want to make the point that this is meant to be really a bit of an interactive session, and there will be time for questions, there will be time for discussions throughout the morning. As much as obviously, like I said, we've got some great speakers and some great projects that we're going to hear around sort of data, and we do want to sort of open it up wider and hear from others as well as around the virtual room, around some of the work that you might be involved in, some of the work that you might know of, some of that innovation, because it's all about really sharing that learning right across the board. So again, thank you very much for signing up today, and thank you very much for joining this morning. This is the first session of the Better Homes and Healthier Lives series as part of the Housing and Healthcare programme, which has been established across the North East and North Cumbria to build on the great work that's been done to date, and to really tackle and mobilise on housing and health and care across the region. The programme is the region's sector-led improvement initiative, focusing on delivering better, more integrated housing, care and support so that people can be healthy, live well and stay independent in their own home. The programme has been co-created by the North East Branch of Association of Directors of Adult Social Services, ADAS, the NHS, North East and North Cumbria Integrated Care Board, the Northern Housing Consortium and the TSA, which is the Tech Services Association, as well as many other partners that are involved throughout the programme of work that we've been doing. So this webinar series that we've kickstarting off today complements the work that's been done to date across the programme, including 2 events that we've held in Durham at Ramside, bringing together housing, health and care professionals across the region, as well as those with lived experiences. And we've also commissioned a piece of work last year through the Housing LIN to carry out a baseline assessment across the 3 priorities, which include warm and dry homes, older people in independent living and those with complex care needs. And that full report has been shared widely. If you haven't seen that report and would like to, I'll share a link in the chat shortly, but I will also follow it up, like I said, in the follow-up email as well, or you can get in touch with any of the programme management team or myself or our events team here at the NHC after this session. Alongside that, we've also developed a 5-year plan across those priorities and what that looks like and what we're hoping to deliver and achieve over those next 5 years. And what we'll be using the website platform to do is really to unpick some of those key findings, some of those key opportunities, some of those key challenges, and explore those a little bit further. And as I says, there's lots of great work already being done across the region, and really it's about sharing that learning. We're not looking here to reinvent the wheel. It's about understanding what works and how do we scale that up and what others can take from that learning as well. So today's session, we'll be exploring the topic of data. We talk about that a lot, right across different sectors, right across different directorates. And we're really wanting to unpick how do we, across housing, health and care, use data to tackle health inequalities and target our services better, really with prevention in mind. We all know that that's really obviously one of our key priorities, specifically around the housing and health space. We will hear from a number of speakers around their approaches in this space and what we have done and doing to date and what that outcome has been across those 3 speakers. Though, as I said, there will be time for questions after each speaker, so please do raise your hand or post a question in the chat and I will pick them up at the end of the session. Each of the speakers. And as I said, we have left some time, hopefully at the end, to have a bit of a wider general discussion and to hear from others around the room around sort of best practice learning opportunities across the region or outside, as we want these webinars to be a bit of a call to action for everyone to take some learning away and look at how you can use the data you hold to work together in partnership to tackle health inequalities, improve housing services and target them to those who need it at the time that they need it. There will be another session next month that will be specifically focusing on social prescribing approaches. Some of you will have, well, hopefully most of you will have received that those details and that invitation as well. But again, we can share any details after the session if you're interested in that as well. And again, that sort of that will follow sort of the similar kind of format. So enough from me. Without further ado, I'm going to pass you on to our first speaker. We have Graham Tuckwell, who's an innovation and product specialist from Carbon Homes, one of the bigger housing providers across the region. And Graham's going to talk about the work that we've started to do as part of the programme, particularly around that warm and dry priority in terms of tackling and identifying those homes that are either damp and mould or at risk of being a damp and mould. And it's about how Graham has been working with the data population team across the ICB to overlay sort of our data and understand what we both hold and how we can target our interventions better. So over to you, Graham.
Thank you, Sally. Yeah, so as Sally said, I'm just going to share some of what we have been doing around, particularly around data sharing and GIS mapping, particularly with some of the ICB, but also some of the wider work that we've been doing as part of Shine. So Shine, for anybody that doesn't know, is a networking group which was created back in 2023 following where we attended the Northumbria Water Innovation Festival, where I believe Housing ran a session around tackling damp and mould. So it was a 4-day event where we came together and we had various people from different housing associations and wider in the room, and actually came up with a number of different ideas and solutions that we could put forward in terms of actually really tackling damp and mould. One of those was really about sharing data and how our collaboration was at the kind of the core of being able to really tackle some of the areas that we really that really face our sector. So we came together and we created this networking group. Since then, we meet regularly every couple of months. Last year, what we did as Shine is we actually sponsored an event at the Northumbria Water Festival, where we actually took one of the ideas that came from the first event, which was around GIS mapping, and we actually spent 4 days bringing the right people together in the room to actually pull something together. So we created what we call the One Map, which is where we've brought together the asset data of some of the member organisations. So One Map is effectively following the 4 days of the event is the asset data of the 7 organisations that were sponsored as part of the Shine event. It sounds really strange to think that we didn't know who has properties where. We know the geography that we cover, but we don't necessarily know the overlap, if you like. So we brought there was a number of examples for where we saw there was a lot of concentration of properties in very small areas. So there is a 1 square kilometre area in Thornaby where there are 5 housing associations with quite large concentrations of properties in, as I say, a relatively small area. So just really understanding where those things are. So as part of Shine, there are 17 housing associations which are members, and we are currently working on a project which will bring more and more of their data into one map. So we will then be able to kind of enhance that that picture. How it generally works is that we've worked with Esri because it was the supplier of the GIS mapping. We have created a Shine account, which will actually bring all of our data together. Our GIS specialists across all of our organisations have worked together to create a GIS club. So they meet every couple of weeks and work on focusing on bringing more data in, as well as the standardisation and usability of the map. So actually, that collaboration is really working really well across one map. What we want to then be able to do is to link into that process and the wider one map is back at the end of last year, we started working with the ICB and SATI at the Northern Housing Consortium to look at where we could bring together some of the NHS data, particularly around respiratory admissions, and how could we link that with some of our housing data. So what I will say is that we are still in this process. So we are still working to pull those sets together. So we haven't actually quite managed yet, but it is still a project that we're working through. But the idea being is that at the data level that we can get from the NHS's lower super output area is that we will look at each of those, and within that area then bring in some of our core housing information. So for example, how many properties that we have in that particular area, EPC data as an example, as well as any other maybe third-party information. So the aim being is that we actually may be able to see some of those links between housing and health. So some of the data, as I say, that we've already got in there at the moment is we're currently showing the percentage of our properties, and we're focusing initially on the County Durham area, just because that's where we've got a higher concentration. But what we've got to appreciate is that as Carbon, we will have a real range of property percentages within an area, because the LSOA areas can be quite wide, is that, you know, that our percentage can range from a couple of percent up to 20, 30, 40, 50%. So this is where linking then into one map would then enhance that, because it will pull more and more of that housing association data together. We've then used some third-party information and data, so things like council tax data, to be able to look at the wider amount of properties within that area. And Jonathan, who is our GIS lead, has been looking at pulling those together. And then what we've looked at is our EPC data initially. So we'll pull that and look at the number of properties that have different EPC ratings and whether or not that will have some indication. At the moment, we haven't got the respiratory admission data in there, but that's one of the next steps, which I'll speak about in a second. So the next sort of stages of this project, if you like, is that the next real stage is, because we've got the basis of the map set up and we've got our data pulled into the different LSOA areas, and we've got our property data, we then need to integrate initially with the County Durham respiratory data. Once we've pulled that in, we'll be able to then see some sort of hotspots. Using that as a trial, we can then look at is there any other additional information that we need, or are there any other additional ways that we want to be able to cut and slice information? So as an example, we may want to look at it by the NHS areas, for example, or GP area, or we might want to put it into, for example, our housing areas and various other things. So we're going to use that as a bit of a test bed to understand what we want to be able to use it for, what is the data telling us, and what information that we might want to bring in that can then enhance. Then we'll look at widening that out across all of our geography. and pull all of that together once we're happy that we have enough of that information in. And then the longer term project would be is where we could then bring that into one map. So going from the properties that we have as carbon, 34,000 property, 20 odd thousand properties, but I can't remember the number off the top of my head. But the bringing all of the data that we have, but then bringing that together with all of the other housing associations that we have in one map. So where we have those areas of concentration of different housing associations, we'll be able to pull together all of their information as well, and then give a much greater picture. So things like where we can see the differences around EPC data, property types, etc., etc. So that becomes the bigger piece of work, and that links into some of the wider work that we're doing as part of one map, of generally just sharing and pulling that data together and understanding what we can really use this for. And that's just a bit of an update. I think it's a bit of a whistle stop, but I was just, if there was any questions, happy to run through.
Thank you very much, Graham. Really, really interesting. And I think, as Graham just mentioned there in his presentation, it is very early doors. It is something we're definitely still, the project's still going on. And obviously conversations still happening with the data population team at the ICB. We're very excited about this. We are starting it very, very small. We are looking, as sort of Graham said, we're just looking at one area, because I think, like Graham said, the opportunities are endless, really. We could really, really go out with this, and we could really, really explore various different areas. And I know through the Shine network that Graham mentioned, they're really looking at that it started really assets and sort of that net zero area. And that's something we're still exploring through other forums, through the North East Housing Partnership as well. So I think, there are wider opportunities there, but I think at this stage, what we're trying to understand is what that could just look like, just by sharing that sort of the data sets that Graham's mentioned, and what that could look like at a very, very small sort of place level, and how carbon, and then obviously health teams in those areas can really use that data to retarget some of those services and understand homes and the people that live in those homes, and where some of those health issues may be occurring. Because as we all know, and more so now than ever, housing and health is very, very much interlinked, and we really, really need to understand them very much so, in terms of trying to sort of understanding what our sort of response is to that. Thank you for the information that's been shared in the chat. Before we go into that, is there any questions, any comments, reflections? Anybody wants to either raise their hand and mute their mic? Graham.
Just an observation, really. I mean, this looks really powerful, particularly around being able to overlay property and health inequality data to then identify which localities have a greater propensity to a certain health condition. I'm just wondering if local authorities are involved, particularly Durham. There's a potential there for private rented sector data to be brought into, and then get an understanding of where the private rented sector exists and overlay that at the same time as well. Just wondered whether or not the local authorities are involved in that area of work.
Sorry, Graham, I don't know whether it's just me, but I think something's gone wrong with the mic at your end. I can hear you really, really slightly though, but you are in and out.
Sorry, it seems to keep on going off a little bit. Is that any better?
Yeah, much better. Perfect.
Thanks. So we've had some conversations with some organisations, some local authorities. Darlington are working and are involved. The One Map project is a bit of a longer piece of work anyway, so they've got a lot of things that need to kind of happen in terms of data standardization and pulling those things together before we can start to pull a lot of the wider sort of data in. But there's absolutely would be a want for local authorities to be involved in that and pull all of those data sets together. I think the aim for One Map is actually, the more information that we can pull together, the more it enriches our understanding of the areas that we work in, and actually how can it really tackle some of those areas. So absolutely, there isn't not, we want the local authorities to absolutely be involved.
I'm just thinking selfishly from a housing association perspective, overlaying it with things like prevalence of damp and mold might be massively beneficial for us in targeting our activity too.
Yeah. Absolutely, and that is some of the things that we've been trialing as a part of the usage of One Map. So we've pulled together some of the organisation's data around damp and mold cases, for example, to sort of see where those are at, and then actually looking at where are there opportunities of looking at kind of property types and age and various. So I think, as Sati said, the opportunities are endless. It's really understanding what those user cases are, how we want to use this information, and kind of what is it that we need to pull together to be able to kind of allow us to be able to do some of those things.
Graham, just going off your point about the damp and mold, that's where this all started from. As I said, I'm sort of leading through the housing and health programme on that warm and dry priority, which is in essence damp and mold. And I think, the sort of question that we've asked ourselves through that programme is how do we target those homes that are either at risk of or already in at risk of damp and mold, and those living in those homes and identifying those people. And as you know, across the housing sector, lots of work's been done in this space around identifying those properties, going in and tackling sort of housing quality issues and understanding the people that live in those properties. So that's where this has come from. And I think the whole idea behind this data map is really to be able to understand where are those properties and across our patches, who is living in them, and our investment plans, our services, are they targeted right, and have we prioritized it correctly? And that's a whole idea of understanding that by sharing this, overlaying it with that health data, which will sort of give us those indicators in the first instance. And going back to that point about local authorities and private rent sector, yes, definitely, it is something we know. It's a big issue. We talk about it all the time across the Northern Housing Consortium, across and with our members. But for the health and housing programme, we've just focusing particularly on social housing at this stage. But as sort of Graham said, the opportunities are endless, and it's obviously up to those housing providers and the local authorities to have those conversations at a very, very local place level to see where else there are those opportunities. And I know through the net zero work stream, through the Northeast Housing Partnership, last week we heard from South Yorkshire, who have got a particular project called Let Zero, and that's particularly focusing on the private renter sector. So it is something we're definitely mindful of. We know that's a bigger problem across private renter sector, and it is something that we'd hopefully maybe look to explore some way down the line through this programme. But I think in terms of the work that Graham's doing, it's something that definitely Carbon might look at with their local authorities as well around that, PRS sector.
I wasn't meant to suggesting that we should be focusing on PRS, Sati. I'm more thinking about where they have them cheek by jowl of our stock, and that suggests that in that locality there's a greater propensity of need. So I'm thinking more about the health side of it from a people perspective. It would be really useful to know that kind of data sets.
Oh, definitely. I agree. Thanks, Graham. Any other questions, comments, reflections? Don't know whether anybody that's put anything in the chat might want to sort of elaborate a little bit more or anything there. No? Okay, brilliant. Well, thank you very much, Graham. And again, we will obviously, once we have something to share through this programme of work that Graham's involved in, we will share wider with the audience here as well. But obviously, and if anybody's got any questions at all, please do just get in touch if anybody wants to hear anything more. Thank you very much, Graham. Okay, the next speaker that we have is Alison Bowles, who's a professor in sociology at the University of Stirling. And Alison, first of all, thank you very much, because it was very last minute inviting Alison along sort of late last week after one of our other speakers dropped out on us. And Alison's going to talk about some of the research and the work that Alison's been involved in around sort of designing homes for healthy cognitive ageing, and how sort of data has been very much used as part of that as well. Alison, over to you.
Thank you very much, Sati. I'll just go for the challenge of screen sharing. Bear with me a second.
No problem.
Okay, getting there. Right, now. Sorry, we're on a slight go slow here.
Fine, don't worry about
I
it.
think this is the screen. I think. Come on.
Coming through. It's coming through.
Coming through. Okay. As long as you're not
Yeah.
seeing my email. Right. You're now
No,
seeing my
can see
PowerPoint,
that.
are you?
Yes.
Right.
Thanks, Alison.
Okay. Well, I really appreciate the opportunity actually to talk to this audience. I know that there's like so many challenges around housing health and support and so on, and it's really welcome to be able to talk to people who are right there on the front line. I'm a researcher, but this project is not all about numbers and things. It's a very applied piece of research that we've done aimed at designing homes for healthy cognitive aging. That may seem a strange phrase. Cognitive change is something that happens to many of us as we age. For some of us, it's going to end up in dementia, and that's our particular focus. But we are incorporating physical support and sensory support as well. I have to acknowledge the funders who are the ESRC under the Healthy Aging Challenge. The research part of the project finished 10 months ago. We're now doing what we're calling impact implementation work, which I'll eventually come to. So the data story on this is one about using different kinds of data to use data to engender action. And you'll see as I go through how that's happened. Now, come on. Right. So the aims of this project, as you can see, were to identify housing innovations to support living well with cognitive change. And I've explained what we mean about that. It was very important to us that these innovations would be appealing for people as we age. You know, age is about everybody. Everybody wants to live in a nice and supportive home. So it's very important that we take into account what people's wishes are. We needed the innovations to be practical, affordable, and scalable. And this is for both developers and providers. There's a strong focus in here across the whole housing sector. And we wanted the innovations to be suitable both for newly built and for existing homes. Retrofit being an absolutely massive issue, but also I think after this project, I would say that a lot of the private builders are just building the wrong kind of housing for the population that we're going to have in the coming years. We wanted to design and test these homes working with stakeholders and in the end to produce guidance. So we worked with a whole range of partners from across the sector, and you can see here we had Scottish local authorities, we had housing associations, we had professionals in the field, including architects and builders. So it was very important that all these different stakeholders had input into the project. You'll be delighted to know I'm not going to go through the whole data set, but it was a massive project and we collected all different kinds of data, including quantitative data from existing surveys, also surveys that we carried out ourselves, and more qualitative work. So I think in general, I would say that the quantitative work provided the context. You know, we understand what the issues are, and then the qualitative work, talking to people and collating all of that, enables us to burrow in and identify what the solutions might be. So, come on. We were positioning ourselves against earlier work, which had been limited in a number of ways. First of all, it had tended not to look at home design in the round. It had focused on particular innovations or bits of tech. I'm sure you're familiar with that kind of thing. There had been very little on costs or the business aspects of this, which I know are foremost in people's minds. Older people had been rather stereotyped in a lot of older stuff. It wasn't about us as we age. It was about them over there, the older people who need different things from everybody else. We wanted to get away from that. There was a tendency not to think about anything at scale. It was all about small stuff. And most of the outcomes had been set out by the researchers. The researchers said, this is what we want to see, without really asking either the older people or the sector what their wishes were. So I mentioned that the quantitative data provides the context, and this is now some examples of how it does that. So we used some existing surveys, which you may be familiar with, the English Longitudinal Study of Ageing and the Scottish Household Survey. And what we find is that older people commonly report having changes in their home to support them as they age. By far the most common types of adaptations are made in the bathroom. So they're not about insulating the house, for example. The kind of mainstream stuff that is so important just doesn't really appear when you think about adaptations. And the adaptations are partly to do with people's personal situation and partly to do with the property. There's a complicated interaction going on there, and people make quite complicated choices if they're in a position to choose about what they're going to prioritise. And I'll come back to that later on. Sorry, the last bullet point just popped up. I didn't realise it was separated. It was much more likely that people had adaptations to their homes which supported physical issues rather than adaptations that supported cognitive issues. And in our minds, that's a problem. Cognitive change happens to a lot of people. It can be a huge issue. It's one of the biggest triggers for carer burnout, hospital admission, residential care submission. In other words, not the kind of older age that we would want for ourselves. We also did an e-Delphi panel to try and sort out what kinds of outcomes people actually wanted. And this involved older people and housing professionals. And it produced quite a strong sense of what an age-inclusive home should look like. And surprisingly, people want a nice home. They want a home that's going to support them because they want to stay in their own homes. They want something that they can easily heat or easily cool. And that, of course, is the other side of that coin. They want it to be adaptable and flexible as their lifestyle changes, whether through choice or circumstance. And they want to be community-based in some way. Interestingly, we found that people readily see that you can adapt homes to support mobility. You can readily adapt homes to support sensory change, but they're much more sceptical about whether homes can support people experiencing cognitive impairment. Sorry, there's a spelling mistake there, I've just spotted. Anyway, this was, by the way, a little bit of a biased audience in that this was an audience that did know a bit about cognitively supportive design. So many of them did know about it, but it was still markedly less well known than support for mobility or sensory impairment. So all this is painting a picture of the context in which we're working. This is an example of some of the survey work that we did, where we collected data from older people about their own houses. And this is data that's really hard to get. The ELSA, for example, only takes a few measures. Many of the larger surveys don't include many older people. A lot of the housing data doesn't include necessarily many older people. We found, interestingly, from this fairly random sample of people across the UK that, surprisingly, unsurprisingly perhaps, there were lots of people who were living with mobility, sensory and cognitive issues, but there wasn't really a relationship between age and increasing issues. So not everybody who needs more supportive home is necessarily getting it. And that's what the little plot on the right shows. I won't go into detail about that. It's just to illustrate. We also, in this survey, looked at what people were doing to their homes, how they were changing their homes as they aged, what they'd done to their homes, and what they were planning to do as well. And this slide, sorry, I've got a little intrusive, that's it. This slide shows what kinds of changes people had made. So all the red ones are about mobility. All the purple ones are about cognitive adaptations. And what the graph is telling us is that people are very, very rarely making changes that support cognitive aging. And there's almost a negative that they're not only not doing them, but the things that they are doing are not necessarily very supportive. Okay, so that's all the background stuff. That gives us a sense of what the problem is. We then moved on to look more qualitatively about what people were experiencing and what they wanted. And we did this by asking people to draw us a map of their home and to talk about it. And the drawing of the map was really just to support the conversation, because it kind of made people think through what was in their home and what they liked and what they disliked about it. So we got very varied maps, from, you know, beautifully drawn on graph paper with labels and careful adjustments when they thought they got it wrong, to quite kind of colourful, funky maps. And we used these to think about how people interacted with their home. So the home, all right, it's a physical thing, but it's also a very social, emotional, experiential thing as well. And how people live in their home makes a difference to how their home performs. So if the house is inclined to be a bit cold, if you don't heat it, it gets colder and you get mold, right? If you do heat it, if you're lucky enough to be able to afford it, then you can keep the mold at bay more easily. We know that. That's almost a trite example, but it really emphasizes what homes are, and this is very important. So in addition to a lot of interviews with professionals, we pulled together the qualitative findings about homes. And we found that what people actually want is to stay independent. They want to stay physically active, and they want to live the life that suits them. And that's different for a lot of people. It's not that when you get old, suddenly your house is a place that supports you. It's still your home, and you're still living your life. And that's often, I think, pushed to the background in some of the discussions around housing. There's, of course, a huge need for change, and a lot of this is around awareness raising for older people and awareness raising across the sector. It's needed in professional education. We probably need changes to legislation, policy and guidance. So it's a huge issue, not underestimating everything. But we did learn some quite useful things. So people change their homes all their lives if they've got the opportunity. They do it proactively, they do it reactively. And the things that they do, they try to do to improve their quality of life and to support their aging in place. It's not that suddenly you get old and your home needs changing. It's been changing throughout one's life. People balance the benefits of making changes with the challenges of the stress, disruption and expense entailed. And this part of our work particularly emphasised the social side of the home, which seemed to have come to the fore even more during and after COVID. So we were collecting this data shortly after the lockdowns. In fact, there was another lockdown that started in the middle of this data collection. So the home is much more about being a social space than it is a place for maintenance, which is the stereotype of what older people need. In the sector, of course, the process of the processes involved in providing good housing are very complicated. And one implication of this is that trying to ensure cognitively supportive housing can just be seen as, oh no, not another thing. So there's a bit of reluctance and a tendency to perhaps not want to think about just another thing. Nevertheless, we did see quite a lot of appetite and demand for supportive housing, especially among social housing providers. But quite interestingly, a lot of the professionals we spoke to said they didn't really want to live in supportive housing. So they talk about, oh, this is needed, that's needed, the other's needed. And we just say, and would you like to live there? And the answer is quite often, oh, no, not for me. So there's a bit of othering going on here. You know, older people are somebody else, not me as I age. It's other people. So we pulled together all of this stuff and we produced a design of a cognitively supportive home, which drew on our data and also drew on what we know about the principles of this. It was designed to be also a lifetime home. So flexible, adaptable spaces throughout, suitable for young families, as well as people as we age. And we put these into a VR headset. And we did 3 rounds of testing this with older people and with professionals. So we ended up with a design that seems to be appealing and seems to be practical, affordable, and scalable. So we ended up with an emphasis on changing needs. So the house needs to be adaptable. We need an inclusive design supporting people with diverse needs. We're not saying that the design is it. We have incorporated in it a whole lot of small things that can be done that can make a big difference. And I'll illustrate in a moment. Flexibility is important, as I said. Current adaptations are often viewed quite negatively. The plastic handles, for example, by the front door says, an old and vulnerable person lives here, come in, you know, and people find them not aesthetically pleasing, let's say. And one result of that is that they then don't use them or they refuse to have them. And that's not helpful in any sense. And there's the neglect of scalability. So just to illustrate some of these principles, we have 2 hallways. Probably the one on the left is a bit prettier, but the one on the right has the benefit of contrasting doors. Now, one impact of cognitive change is that one's perception goes a bit. This can also be as a result of sensory changes in sight. And if we just take this on one, I'm going to blur it a bit, which is one of the effects of cognitive change. Come on. Now, which one can you get out of? See, the lack of contrast is a really big issue and can cause people to not be able to find their way, to feel trapped, and so on and so forth. So introducing contrast is very helpful as we age cognitively and sensorially as well. Access, here's just quite a simple illustration. The bathroom on the left is a bit tight. There's not much space in the middle if you have to use a walker or a wheelchair or anything like that. It also has a big step into the bathtub to use the shower. The one on the right, quite simply, has a more accessible showering facility, a little bit more space, and it also incorporates contrast. So the one on the right has features which can support people cognitively, sensorily, and physically. This is from our online walkthrough of our design, which you can look at. And this is the version which is both cognitively and physically supportive, in that the bit with the sink and the hob is a wheelchair user height. It's not difficult to raise it up or move it down. I'm sitting at a desk that goes up and down at the touch of a button. These things are more and more used. The little spots, as you'll find if you look at our online resource, provide additional information. So there's a spot, for example, over the glass doored cabinet. There's a little explanation of how glass doors can be useful for some people, but other people may not want their mess on show, which is a piece of feedback that we had. So for any individual, the choice can be seeing through the cupboard, having labels on it and having it more closed, whatever. The principle being it's easy to find where stuff is. And there's an example of labels as well in here. And here's a bedroom, also supportive, also from our online resource. A key thing here is you can see the toilet from the bed. May not look like it, but you can. It's slightly distorted in the still version. The bedroom looks huge, but it's specified so that if somebody needed a hospital bed in there, there's enough room. Hospital bed adds, you know, a good foot to the length of the bed, so it needs to be of a decent size. Nearly finished. So these are some of our key outputs, which I hope people find interesting. We've been doing lots of presentations and things, trying to publicise it, lots of knowledge exchange. We're drawing up professional training events and materials, which will be on the website in due course. We have a downloadable booklet illustrated up here on the right, which takes people around their own home. It starts by saying, have a look at your front door. Can you distinguish your front door from all the front doors in the street? Are you allowed to paint it a different colour? If you do, this might help you or a loved one in the future to find it. Or is there something else you can do? You know, can you put a bright red geranium there that says, this is my house? Obviously, that won't work all year round, but it's those kinds of things that we're recommending. And they are deliberately, in many cases, not complicated and not expensive. And where we use illustration, we try to illustrate things that are high street level purchases. So, you know, we're not saying go to a fancy kitchen manufacturer and get a bespoke kitchen. We're saying you can find this in Wicks. It's about thinking about your choice of colour and where you put the glass fronted cabinets in the kitchen, things like that. We have the demonstrator designs, as I've just illustrated online, which have a walkthrough with them. We have a serious game, which is intended for everybody really, but we've used it particularly with professionals to help think through decisions when they're thinking about housing developments. And this can apply to retrofitting or new build developments. And it encourages innovative thinking and working through decisions in relation to real scenarios that come from our research. We've got a costs and benefit guide, and we will in due course have a design brief for professionals. The serious game has an electronic version which we're about to upload. It also has a face-to-face version which we sometimes deliver ourselves, and we're going to be delivering in partnership with an external company. So hopefully that illustrates the journey through analysing existing data, collecting new data, finding a solution, and then delivering it. So thank you very much for your attention, and happy to answer questions, of course.
Thank you so much, Alison.
Sharing now.
Brilliant. Just to champion the serious game, we did that through this programme, and we brought it across various different health and housing and care professionals again, just to start to think through sort of the 3 key priorities of our programme. And like it says, it's that innovative thinking, sort of working in different roles and looking at it from a different lens. I think we've, you know, the feedback was really, really positive. So you can definitely vouch for the serious game. Thank you, Alison. Really interesting. I think, you know, obviously there's a lot of points there that are quite big takeaways. But I think for me, one of the ones that stands out for me is that thing around, you know, when people think about adaptations, and it's always about that physical sense, and you never think about that other side of things, particularly with your point about the retrofit, which is obviously a big piece of conversation that we're having definitely across the housing sector, and how it does link into sort of the healthy homes sort of conversation. Okay, any questions, reflections, comment? Charlotte's just posted there saying really interesting and great
Thank you.
person-centred approach to your research, which is definitely something that I think is very much welcome. And I know we're definitely looking at it from across the northeast North Cumbria around that sort of lived experiences and bringing those voices in when we're looking at anything. Any other questions or reflections? Okay. Thank you once again, Alison. Really appreciate your time. And again, thank you very much for stepping in very last minute. You'll obviously said when we share this recording, you'll have obviously all the slides and the links and the contact details. And obviously, if there is anything at all that you'd like to follow up, please do either get in touch with ourselves at the Northern Housing Consortium, anybody through the programme board, or obviously with the speakers directly that you've heard from today. Okay, our final session speaker for this morning is Rhiannon Clark, and Rhiannon is a senior programme manager at Health Innovation Northwest Coast, and Rhiannon's going to share the work that Rhiannon's been involved in across the sort of Cheshire sort of area around the use of data in tackling fuel poverty, which is again something I know a lot of our housing sector is doing lots of work around, as well as some overlaying that into sort of the health space as well. Yes, we will share presentations as well. Like I said, they'll all be on the recording as well, Emma, so no problem. Thank you very much for joining this morning. Okay, over to you, Rhiannon.
Thanks, Sati. I'll just try and share my slides. Has that worked?
Yes.
Brilliant. So, good morning, everyone, and thank you so much for inviting me to speak today. Before I explain about our project, I just wanted to kind of introduce myself and give you a bit of background as to how this work came about. There we go. So my name's Rhiannon Clark and I'm a senior programme manager at Health Innovation Northwest Coast. I'm not sure how familiar you are with the Health Innovation Networks, but basically there are 15 of us across the country, and we were established by NHS England in 2013 as the innovation arm of the NHS. So we work with healthcare organisations and businesses to support the spread of all kinds of innovation within the NHS, and that can be from new technologies to new ways of working and service improvements. And we do that to improve services for patients, to enable NHS efficiencies and to support economic growth. So I'm part of Health Innovation Northwest Coast, which covers Cheshire and Merseyside and Lancashire and South Cumbria. And this project comes under the umbrella of the Innovations for Healthcare Inequalities programme, INHIP. And that's a national programme from NHS England's Accelerated Access Collaborative. It was developed to focus on healthcare inequalities using the Core 20+5 approach. Each health innovation network is supporting their ICSs to scale NICE approved product-based innovations aligned with the Core 20+5 approach and local ICS healthcare inequalities improvement priorities. So nationally, there was a total of £4.2 million made available to support the programme, and it was awarded in a non-competitive process with £100,000 earmarked per ICS. So just to give some background, in 2020, Ofgem estimated across Cheshire and Merseyside that 14% of the population were in fuel poverty. In 2022, that was set to increase to 42% in line with the expected fuel rise. And that equated to over 450,000 households across Cheshire and Merseyside. We know winter's challenging for all those living in fuel poverty, but particularly so for those living with respiratory conditions like asthma and chronic obstructive pulmonary disease. It's well known to exacerbate these conditions, and those patients are at greater risk of admission to hospital over winter. So in Cheshire and Merseyside, it was decided that our focus for the INHIP programme was going to be on respiratory patients. And we wanted to develop a fuel poverty dashboard using their Cypher data platform that's combined intelligence for public health action. Cypher's a linked data platform which brings together health and social care data from right across Cheshire and Merseyside. It was originally established to support the region's COVID-19 response, but it now helps NHS and partner organisations right across the ICS to understand and map population health data to support service design and improvement. A fuel poverty dashboard was developed within the CIPHER data system, which identifies the population cohorts at greatest risk of harm by bringing together several data sets, including the CIPHER primary care level patient level data, SUS data, local feeds from providers like the Pregnancy Register, the Office of National Statistics fuel poverty by lower layer super output areas, LSOA, and Department of Levelling Up Housing and Communities energy efficiency data. So we work with several partners, including GraphNet, who provides Cheshire and Merseyside's CIPHER data platform. And they're the ones who created this fuel poverty dashboard within CIPHER to help us shape the cohorts and identify high-risk patients. We also work with Optum UK, who provided consultancy and engagement support throughout the programme using their population health management approach. They facilitated workshops for us attended by representatives across the ICS to determine the cohorts we were going to look at and the key interventions that would support them. Through that engagement, we decided on 2 cohorts. Cohort 1 was patients with severe COPD and cohort 2 was patients with preschool wheeze. So local clinicians and care professionals spanning NHS, local authorities and the voluntary sector then took part in a series of place-based facilitated workshops led by Optum, which presented an opportunity for teams to understand and interrogate the local data and then work together to develop targeted actions to support people at greatest risk. As well as defining outcomes, those sessions explored how the patients would be engaged and communicated with, what specific interventions should be delivered and by whom, and what sources of information would be needed to track progress and measure impact to this work. These workshops were really successful and have formed part of the phase 2 of the programme, which I'll talk a little bit more about later in this presentation. So this looks a bit overwhelming, but I just kind of wanted to show you what the dashboard looks like. So this is our COPD fuel poverty cohort in Cheshire and Merseyside. The numbers are too small to read on here, but the total number of patients that met the criteria are in the blue box across Cheshire and Merseyside, and that was 1,137. We initially started this work in Knowsley, in St Helens and in Warrington, which I've circled in yellow there. So the pathways that we developed in each of the areas are really quite similar, and they all included a nominated person. One area used a care coordinator, one a physician associate, and the third uses a respiratory specialist nurse to access the dashboard and create a list of patients. The clinical team then undertake a review of the patient and refer to the other services, and they include things like occupational therapy assessment, community mental health support, pulmonary rehabilitation, smoking cessation, social prescribing, and local authority funded schemes. In St Helens, that also included a £500 household support fund payment. Some of our local authorities commission a charity called Energy Projects Plus to deliver their fuel poverty interventions. Ooh. Sorry, I forgot it was a dynamic slide this one. Oops, too far. So Energy Projects Plus have got a number of projects in place with our local authorities right across the ICS footprint. And this slide just shows some of their offerings, which include things like switching to lower energy tariffs. They can organise loft or cavity wall insulation, boiler repair or replacement, support to clear fuel and water debts, referrals for free white goods, emergency fuel credit vouchers, referrals for benefit maximisation advice, and installation of what we refer to as easy measures like LED lighting and draft proofing, things like that. So you can see from this slide some of our latest impacts. So we've had over 380 patients identified and put onto the fuel poverty pathway, facilitated over £275,000 worth of payments from the Household Support Fund. There've been over 250 referrals to affordable warmth schemes, 323 referrals to wellbeing and social prescribing teams, smoking cessation, health trainers, weight management, that kind of thing, and over 45 referrals to pulmonary rehabilitation. And here's a nice picture of the St Helens Community Respiratory Team. Now, I was going to share a patient case study with you, but I thought it might be better to share a clip of Diane Green, who's our lead nurse for the Community Respiratory Service in St Helens, and she's talking through some of the patient impacts, and she does it far more eloquently than I could. Can you just let me know if the sound's sharing once I play this, please, Sati?
We've had patients say to us that we've transformed their lives. We've had a gentleman who had a wife and daughter who suffered from mental health, who has had new windows, damp course done in the house, mould has been treated, the walls have been replastered. They had a hole in one of the floors in their bedroom, so the daughter was actually sleeping with the mother and the husband was sleeping on the couch downstairs. That's now been rectified and the girl has her own room and the husband's now sleeping back upstairs. And since that intervention, he had had 3 previous hospital admissions, and since the intervention has had none. Another patient who had mould in the house, their children refused to visit because of the mould on the walls and the state of the property. And they now visit regularly because all that work's been done. Patients are so grateful. You know, we're just at the tip of the iceberg. We've had patients say to us, I didn't believe it because this is too good to be true. It's just been a different approach. It's given the team more insight into the internal stresses that patients have. You know, as community nurses, we've always been very privileged in what we've been able to do, but this is definitely a step up from what we're told is proactive care. This truly is proactive care. This is holistic and looking at the causes of hospital admission. And one of the causes is patients living in a cold, damp home with financial constraints and financial worries. So now by giving them holistic care, the patients can keep their houses warm, they can buy healthy food, which increases their health status and improves their overall quality of life. We've had
So cohort 2 was originally going to be children with asthma, but on reflection, it was felt that children with a confirmed diagnosis would at least be on a list for annual reviews. Children without a confirmed diagnosis are at greater risk of poor health outcomes. Some of the children identified by this work had received up to 26 salbutamol inhalers within the last year, which is just absolutely shocking. So we began delivery of this cohort 2 work in St Helens, and we're still quite early into this work, but here are some of the outcomes to date. So the work's looking really promising and it's linking up similar interventions to those in the COPD pathway. To date, there have been 103 applications to the Household Support Fund distributed to families for helping towards energy bills. So that's £51,500. There have been 60 registrations for priority services, 184 light bulbs given out and 6 referrals for replacement boilers. Anecdotal feedback from parents at review appointments tells us that these children would usually have been taken to A&E, but since attending the clinic, they haven't needed to. It's also been reported by parents and the clinic team that patients have found it easier to attend the Low House Children's Health Hub than Wiston Hospital. And there's been a reduction in non-attended appointments for the respiratory nurse specialist as it's more accessible. So that results in a reduction of DNAs and NHS wastage. One of the outputs from this work has been development of an implementation toolkit to help other areas to adopt this approach using resources we develop with our Trailblazer sites. The toolkit's hosted on our HIMWIC website and it contains things like dashboard information, case studies, an asset map of organisations that we've worked with, our learning to date, example process maps and SOPs, links to webinars and interviews with the teams delivering the work. And we've also got a short-term evaluation that we produced looking at the interventions delivered so far. We shared that toolkit via social media and it was also sent to the place directors of each of the 9 places within the Cheshire and Merseyside ICB in a tailored place director pack with data specific to each place. The toolkit is also on the INHIP NHS Futures site and it was shared across the Northwest as part of our weekly Health Inequalities bulletin. There's also a link to the toolkit on the NHS England INHIP resources page, and we're planning to relaunch an updated version of the toolkit in the next couple of weeks, so please keep your eyes peeled for that. So what next? The University of Liverpool are involved in the longer term evaluation using their RICE tool. So sorry for all the acronyms. It's Real World Intervention Causal Evaluation Tool. And they've identified matched cohorts in Cypher to compare our patient cohorts with. That only started recently as we had to wait for a minimum number of patients who have been put onto the pathway and then to be on the pathway for 6 months. But we're really excited to see those results. At the end of phase 1, we held an online lunchtime session to celebrate the successes of the Trailblazer sites and to bring together place leads from across the ICB, local authorities and voluntary sector to look at what could be done in their areas and what support they might need. InHIP continued as a programme for 24-25 and also for 25-26, which means we have and will continue to support the fuel poverty work in Cheshire and Merseyside. We've continued to help facilitate workshops and support pathway designs with teams. We've got 2 areas hopefully going live in the next month, and we've got another 2 areas that we're working with, setting up workshops to design their interventions and pathways. I've included a nice quote from our ICB respiratory lead, Sarah Sibley, here. And I think this is exactly right. This work's been a brilliant example of the power of cross-sector working. This slide just shows some of the partners that we've worked with across the NHS, local authority and charity and third sector as part of this project. The strength and the value of this project hasn't been in creating a brand new service. It's been all about putting data, smart data into action, using our data systems to identify people most at risk of poor health outcomes due to fuel poverty. The innovation really lies in the approach of bringing multiple services and sectors together into one pathway and enabling those resources that are available to be proactively targeted at those most in need. The approach has provided value for money and improved patient experience by joining up the offers that are available, recognising that poor health can't exclusively be tackled with clinical interventions. There's just no point putting people on expensive cutting-edge therapies and then sending them home to a cold, damp, mouldy home. They're just not going to get any better. A senior member of one of the clinical teams recently commented that this was the most impactful project she's ever worked on in her career, as the information available in the dashboard and the links made with other services has enabled her to really support patients with the issues that both directly and indirectly impact on their health. And I'd just echo that and say this is an incredibly powerful piece of work and approach that's hopefully going to be embedded right across the ICS and further during the next phases. So thank you so much. I'll just leave this slide up for a second with the link to the toolkit and my email address. But if anyone wants any more information or to have a chat about the work that we've done or are planning to do, please just reach out. Thank you.
Thanks, Rhiannon. That was definitely very powerful. Really, really interesting stuff, actually. Really great. And again, it's another example of the power of data. And if we use it right and we get the right partners, what we can do and the difference we can make to our tenants, patients, customers' lives and the people that live in our areas. So absolutely fantastic. Brilliant. Any questions, reflections, comments? There's obviously loads of positive comments in the chat around how interesting it is and sort of the impact it's had to date. Anything from anyone? You're a quiet bunch this morning. Go. Thanks. Diane.
Hi, Sati. Hi, Rhiannon. I'm from the housing sector and innovation, but I was just really interested to see, did you see that there were any barriers to the work? Because obviously it's for a really great benefit to the NHS, to housing providers, but we should be doing that already. Is there anything that you would say that was a challenge or a barrier or learning that you'd suggest for other regions?
I think there's tons of learning that's come out of this, and like I say, we've done a bit of a short-term evaluation and kind of pulled together that learning, which you're really happy to share. But I would say that the kind of the biggest barrier to get these projects off the ground has been the health side rather than the local authority or charity side. Whenever we talk to any local authorities or housing providers, they're like, yes, we want to be involved, please, any way that we can. Yeah. There's obviously the NHS is really stretched, like we all know that. So people are very hesitant to do something new, but like I've hopefully tried to emphasize throughout that this isn't something new, it's just something a bit differently. And I think once we talk through things and realize that we're not asking people to do anything in addition to what they're doing, it's just something a bit different, those barriers did break down. And I think the fact that there's been no direct funding associated with this, can be a bit of a barrier for us. Oh, you're not going to pay us to do this. But once we talk through and the patient benefits and getting people like Diane that you heard from there to come and speak to the teams, it really kind of motivates them to get involved in this. So hopefully breaks down
Right.
those barriers. The one other barrier that kind of springs to mind is obviously that our data system is dependent on data sharing agreements, because lots of this, especially with primary care and with the call to action with GPs at the moment, that has kind of made it slightly more difficult from the data sharing point of view.
Great, thank you.
Yeah, sorry, before bringing Tony in, I think that was going to be my question around, particularly around that data sharing, how you overcome that, because I think, again, just in some of the early conversations that we've been having with Carvin and from Graham's presentation earlier, those are some of the things that have just come up. And like I said, this is just at a very, very sort of small base level, which, you know, we want to roll it out wider, but it's how do you overcome that? And I know in the areas that it has been done, so it can be done, it's just how do you do that? And I think it's back to that point you made, Rhiannon, about just in terms of that wider sense of it's not anything, we're not asking you to do anything in addition, it's just doing what you're doing, but doing it differently. And I think that it is all comes part of that conversation, doesn't it, really?
Yeah, and I think it sounds controversial, but I think the whole kind of response to the pandemic has kind of helped us, because it did put this data system in place that was developed to respond to the COVID-19 pandemic. So the data sharing agreements were put in place at that time, and that kind of established this data system, and then it provided a proof of concept. It works. And then, you know, now we've got this fantastic data system. So
yeah,
that is a
I think
positive.
just again, definitely. And just again, sorry, Tony, I will bring you in a second. Just something that Amy's just put in there in the chat about sort of barriers. And I think, I suppose, again, it's like who holds it. So whoever is it covered by? So obviously, I suppose it feels like an area that is typically covered by social care, was it housing? That may also cause some resistance from health colleagues in terms of actually who is sort of leading on it and where does it stand. And I think it's against back to this thing, it's about changing that mindset. It's not about who's leading on it or where it's coming. It's all about the outcomes, isn't it? And we all want the same thing for whether it's our residents, whether it's our tenants, whether it's our patients, whether it's, you know, it's the communities. At the end of the day, we all want them to make sure that whatever we do, it's about their health and well-being.
And I think that's another thing that we've benefited from, that obviously this is, you know, I, as in from the Health Innovation Northwest Coast, have worked really closely with the ICS. So we've got total buy-in with the ICS. In fact, the executive medical director is actually our clinical lead for this work, and that does open a lot of doors and add a lot of credibility to this work when you're going out on a place level.
Yeah. Sorry, Tony, you've been waiting there patiently.
Yeah, that's fine. Thank you. It's been a really interesting morning. I know that my address there, I think on the caption says DWP. That's my day job, but I'm also in here, and I'm here today to represent Newcastle Elders, as well as being the chair of the Customer Voice Group of Newcastle Council's housing service, as well as a resident. And I think just one of the important things to think about as well is how, and I suppose brings the DWP into some extent as well, how work is also beneficial to health. And there are so many people now that 5 or 6 years ago weren't, are working from home. And it's about that consideration about homes that are fit to work in. If you've got damp and mold at home, you then seem to have that damp and mold because it becomes your workplace as well. So I know there's a limit to what housing providers should be thinking about and providing, but it's one of those things that can sort of make a difference there as well. I mean, I never expected to have to work till I was 67 a few years back, but I do now. I thought I'd be retired by now, but I've still got another 4 years that I need to work. And I'm contractually now a home worker. And that's one of the things just to consider about. Luckily, I've got a large living room. But I think I would struggle if I didn't have that. I'd struggle to actually do the job if I couldn't work from home because of disabilities and what have you. But yeah, just one of those things to think about in addition to what's going there. People are working longer. People are working at a more advanced stage. And again, it's just one of the things to think about. But brilliant, everything else that's going on. Really impressed by some of the stuff that's going on with adaptations that are flexible and how much doing that could save money in the long run.
Yeah, thanks, Tony. I'm just picking up on some points in the chat, and Janelle, do you want to sort of unmute and just expand on some of your comments? Because I think that's really, really interesting. And it's really interesting the points that you've made about that single point of contact just through our work to date through this programme. That's something that we're coming across time and time again, which sounds quite simple. And I'm not saying it is, but that seems to be one of the bigger barriers, just having that one simple contact across housing and health, especially when, you know, when you're going out on a particular visit into people's homes and something might be raised and you're thinking, right, okay, that seems like a bit of a housing issue. So who's that sort of one point of contact? Janelle, did you want to unmute yourself, or are you just happy just to post in the chat? Right, okay, fine. Well, Janelle's just sort of said that they've obviously created a pathway across sort of Northumberland and to improve that communication. So it'd be good to hear a little bit more about that. I'm just sort of looking at anything else. I think I see some, you know, people sort of make comments about maybe think about adaptation service and some thoughts about new build designs, tweaks to bungalows, and obviously just really impactful stuff. But yes, okay. Any other questions, reflections? Brilliant. Thanks very much, Rhiannon. And obviously you've got, like he says, obviously on your slides, there's various different links around your toolkit and how others can sort of look to adopt that. And obviously if anybody wants to contact you individually, which I think a couple of colleagues have said that they might, they've got your contact details. But I think it's really, really interesting and might bring you back at some time point in the future about some of those other sort of areas that you're rolling out into and what that looks like and some of that learning from there. But thank you very much again for your time today, Rhiannon.
Thank you.
Okay, so that brings us to the end of our speakers and our presentations this morning. And thank you all again this morning for all of your time. And again, like I said in my opening, we just want to leave some time just for a bit of a discussion, really, because again, one of the aims of this webinar series is that bit of call to action. So it's about bringing everybody together across that sort of housing, health and care piece across the region to really sort of to understand and share what else is going on in this sort of data space, what other work is going on out there, what can we be sharing with each other, what do we need to be aware of, where are sort of some of the other innovations or some of the other opportunities or anything else really that anybody wants to sort of share, discuss, ask. I suppose it's over to you. If anybody's brave enough to kickstart it. Thank you, Heather.
Hi guys, so I'm Heather, I'm from Home Group, so working for a housing organisation, but I'm a psychiatric nurse by trade. And I suppose one of the aspects that hasn't been mentioned today is about mental health and understanding that I would say roughly 80% of the customers in our supported services have a comorbid mental health problem, but that it also adds to things like the damp and mold through self-neglect, through hoarding. And so actually we probably need to be considering what the influence of that is on kind of, it's great if we can kind of resolve these things, but in working with a lot of our housing managers, a lot of the problems are about gaining access to do repairs, gaining access to kind of review maintenance of properties, and that it's the mental health problems that are often the barriers to us getting engagement and being able to work with people. So I suppose we can't just look at physical health stuff without taking into account all the mental health stuff.
Yeah, totally agree, Heather. It's definitely something that's very, very much like it's been discussed right across the sector and wider as well. And I know just through the presentation that we've heard from Graham this morning, some of the conversations in sort of the early time of the project as it was established, we talked about one of the data sets around mental health, particularly those on sort of tablets around antidepressants and how that sort of links into that. And again, it might be something that we might pick back up again with the ICB population team about how we bring that into the sort of conversation as well. But it was definitely something that's mentioned. But I don't know whether anybody else from either the audience today that have joined that either is specialist in mental health or any experience in mental health, or any of the speakers that can share anything that might be already that they're aware of, or anything else that we can think about across our region.
No, we're the only ones.
No. Okay, right, Graham.
Well, really, I was just coming on. I was a little bit slow on raising my hand, I'm afraid, Sati. But just coming on the back of what Heather said, I completely see that. We have exactly the same experience, particularly where there's poor mental health or hoarding tendencies. Gaining access is proving really difficult in some circumstances. At the more perhaps extreme end of that particular range, but we do have access issues. I do think, from a health professional's point of view, intuitively, it feels as though it would probably be easier for a community nurse to gain access to a property than it would be for a housing provider. But we've tended to try and pair up and work with them and do joint visits where we possibly can, where we know there's a community health provider involved or social services involved. So that does help. But it tends to be, it is a difficulty that I don't think we have the answer for. We're trying everything we know we possibly can. But also at the same time, as a housing professional, our tenants do have a lot of trust with us as well. So it tends to be those people with really poor or really difficult mental health issues and hoarding tendencies that we struggle the most with gaining access to. So I back up exactly what Heather's saying.
Yeah. And I think, again, this is at the next webinar, so it helps with my plug. But we'll be talking about social prescribing. And I know, obviously, Graham, the team at Living, have done some work there around really starting to strengthen those connections with the local social prescriber network, and something that we'll be discussing. And Andy Coulthard from Living will be speaking at that next session in February about the approach that's been adopted there. And I think, again, that's a really, really sort of powerful segue into how to work together and how to maybe, like, as you've just said there, Graham, about those joint up visits, or just having that, as it's already been mentioned through the chat, of that one point of contact, and just knowing who those contacts are that exist across our local patches, just to make it that little bit easier. Because I think hoarding seems to be another big priority and a big challenge at the moment. Again, I know that this was something that came to light across at the time of COVID. But I think, again, just through some meetings that I've been to, it's definitely been mentioned more and more. And it was mentioned at that session that you held at Living, with all the social prescribers as well, that the social prescribers reporting that hoarding was back up on that agenda again. So I think it's like it says, it's just trying to work together where possible, have an understanding of what else is going on and who else might be able to support. Because I think, again, access is a bigger issue as well across the housing sector at the moment as well, isn't it, sometimes, in some areas. Thanks for that. Anything else from anybody? Like I said, use this opportunity. You have 38 people on the call. If anybody wants to ask a question, anybody wants to understand what else might be going on, or share some of the good practice, it doesn't have to necessarily be related to data. It could be anything and related to sort of anything about, how we work together and how we collaborate in terms of improving the population health and well-being. Okay, no problem. Well, I'm going to give you 35 minutes back of your time, which I'm sure none of you will complain and hate me for. Well, thank you so much to everybody for joining this morning, for your contributions, to our speakers for taking time out and sharing their approaches, and absolutely some fantastic work that's being done out there. As I said, we have recorded this session. We will share the link and share the slides, and I'm not quite sure where exactly that will be hosted. I'm talking to the comms team at the ICB. I think it will be held on the Boost platform, but like I said, everything will be included in the email with any clear instructions. And obviously, if you have any questions, any follow-ups, any queries in the meantime, please do get in touch. We'll also be potentially sending out a feedback form. So any feedback, it'd be really appreciated, good or bad. This is, like I said, it's the first in a series, and we'd like to sort of hear from yourselves in terms of what we're doing well, what we're not doing well, and how we can sort of improve, and any areas that you might want to hear about going forward. Any case studies that you can share. We'll be hosting a sort of good practice bank, because this is, again, like I said, it's not really about reinventing the wheel. There's lots of good practice out there, and we'd just like to sort of share that as widely as possible across this sort of housing, health and care space. But thank you very much for your time today, and enjoy the rest of your day. Thank you.